Yes, thank you. Thank you to the organisers for inviting me. I'm delighted to be here. So I'm going to talk about porphyria, which it's really difficult. It's a tough gig, this one, because no one really wants to talk about porphyria. This is a tricky area because it's biochemistry and we sort of try and learn it, but it goes in one ear and out of the other, and it's hard to remember, and it all gets in a bit of a muddle. And the result of this is that no one really wants to engage with porphyria. But I've been as a photodermatologist, I've been involved in diagnosing and managing porphyria for a long time, and I really enjoy diagnosing and managing patients with porphyria. They're a fantastically interesting group of conditions, and so what I'm going to try and do today is to give you a sort of a really simple overview of porphyria and make the whole thing understandable. That's the aim. I really hope I achieve that. So the first thing to do is a little bit of background is that a couple of important things to grasp about the porphyrias. So we heard from the previous talk that photosensitivity, such as in solar urticaria and chronic actinic dermatitis, can occur to visible light. And that sort of feels counterintuitive to most of us, because the thought of visible light doing anything to the skin that could be harmful just doesn't ring true. So it takes a while to grasp the significance of that. And the thing about the cutaneous porphyrias is that they're all mediated by visible light. So this is all the effects of visible light. And in the most severe of the cutaneous porphyrias, Gunter's disease, congenital erythropoietic porphyria, which I'm not going to talk about today, it's a severe photomutilating disorder. So sensitivity to visible light, it can be really, really serious. So this slide just illustrates two important things. If you can see on the left there's a sort of black machine with a purple tube in it. So that tube has got serum in it. And if you shine light on the serum from someone with porphyria, there are two things that can happen. Firstly, the energy of the light gets absorbed, and you can measure the absorbance that's taking place with a detector. And what that tells you is that porphyrins absorb in the visible part of the spectrum, so 400 to 410 nanometers. So that's the first thing to really grasp with the porphyrias. The second thing is that the absorbing light gives the porphyrin an opportunity to do something with that energy. So it can either release that energy in the form of fluorescence, and you can measure that fluorescence with a detector, and that gives us the opportunity to diagnose the porphyrias according to their fluorescence pattern. But it also gives the porphyrin an opportunity to produce damage to the skin by releasing that energy in the form of free oxygen radicals. So there are 8 porphyrias, but only 6 of them have cutaneous manifestations. And time is limited, so I'm only going to talk about those 6. And because time is very limited, in fact, I'm only going to talk about 3 of those 6. So things are really looking up. You know, cough is coming, and we've only got 3 conditions that I'm going to talk about. So, and those are porphyria cutanea tarda. I can see smiles in the audience. People are starting to warm to this talk. That's great. So porphyria cutanea tarda, because you're all going to see PCT. So you've got to know about it, and it's quite an easy, it's a very satisfactory disorder to diagnose and manage, and I'll explain why in a minute. Variegate porphyria is also important for different reasons. And then my favourites, I know you shouldn't have favourites, but I have got a favourite in the porphyrias, and that's EPP, erythropoietic protoporphyria. It's a terrible tongue twister of a title, which is why we all call it EPP. So So then the next thing to grasp, and this is part of what makes the porphyrias so interesting. Of course, we're talking about disorders of the heme biosynthetic pathway, and there are a number of steps in that heme biosynthetic pathway. And if you block if there's a deficiency in one of those enzymatic steps, then what happens is there's a build-up of the precursors to that step, enzymatic step. And that build-up is porphyrins. And depending on the pattern of porphyrins, you end up with the different clinical manifestations. And broadly speaking, there are just three things that happen with this build-up of porphyrins. So the first is acute, painful photosensitivity. And this is what happens in EPP. And what X-linked to EPP, I said I'm not going to talk about it, and I won't, but it's basically EPP with a different mechanism and different genetics, but the same clinical manifestation. So acute, painful photosensitivity. So we'll come back to that. The second category is skin fragility with blistering. So this is what you see in PCT, and this should be quite easy for us to diagnose because there's a whole constellation of clinical signs, and that's what we're good at, and that's what we love doing as dermatologists, looking at the skin and piecing together the clues and coming up with a diagnosis. And you can diagnose this condition clinically, which makes it a fabulous condition for us. And then the third possibility is skin fragility and blistering with acute neurovisceral attacks. So this is way more serious. Acute neurovisceral attacks, what that means is the autonomic nervous system shutting down, parts or all of it. And that's pretty serious. That has major consequences. We can't operate with our autonomic nervous system shutting down. And there are two conditions in the cutaneous porphyrias where we see that, but only one that we're likely to see in clinical practice, and that's variegate porphyria. So those are the three that we're going to talk about for the rest of this talk. So, how do you go from visible light to sun-damaged skin? So what happens is you get an interaction between the porphyrins in the skin and visible light. So many of you will be aware of PDT, photodynamic therapy. So photodynamic therapy is just using exactly this. So it's in fact using protoporphyrin 9, which is an exquisitely photosensitizing compound in the context of abundant oxygen and bright visible light. You get massive creation of free oxygen radicals, and these free oxygen radicals cause direct damage to whatever they come into contact with. So it can be protein and lipids and DNA. But that's not the end of it, because the free oxygen radicals also cause indirect tissue damage by degranulating mast cells. So many patients with porphyrias cutaneous porphyrias get urticated skin reactions, complement activation, and metalloproteinase activation. So you can see you've got quite a lot of things, quite a lot of potential things going on in the skin, and that partly explains why you get such a range of clinical features in these conditions. So, how do we diagnose? So, a diagnostic approach to cutaneous porphyria. So the first thing to say is, despite what your textbooks tell you, we never do skin biopsies to diagnose porphyria. Skin biopsy is not required. So porphyria centers around the world do not do skin biopsies when we come across patients with blisters where we suspect that they're suffering with a cutaneous porphyria. So the simple test is which your lab should be doing as a sort of initial investigation, is the plasma porphyrin fluorescence emission scan. So this is where you shine the light into the serum, which contains the putative porphyrin and then measure the fluorescence. And what you can do is divide the 6 cutaneous porphyrias into 2 lots of 3. So immediately it makes things much easier. And basically, if the peak is greater than 623 nanometers, then you're into the category of variegate porphyria and erythropoietic porphyria. But if the peak, the fluorescence peak, is less than 623 nanometers, then you're into porphyria cutanea tarda and 2 extremely rare variants of porphyria, CEP and HCP. And then the third thing that this test can do is exclude cutaneous porphyrias, because if the fluorescence scan is negative, then it will not, then that means there is not active cutaneous porphyria. So this is just a graph to show that. So the solid line shows coproporphyrin, which is increased in I've left out PCT. PCT should be on that as well. So HCP, CEP, and PCT. Whereas the protoporphyrin line, you can see the peak of fluorescence is above 626 nanometers, and that's as seen in protoporphyrin 9, and that's raised in variegate porphyria, and there are 2 variants of EPP. So we'll just focus now a bit more detail on the clinical features. So for PCT, it's usually easy to diagnose from the clinical signs, but the thing to remember, the sting in the tail in this condition, is that basically the cutaneous features are exactly the same as in variegate porphyria. I saw a massive amount of variegate porphyria in South Africa. I went on a 3-month elective in Cape Town. There's a big porphyria centre there, and they have huge numbers of patients. They've got 30,000 patients with variegate porphyria in South Africa, all as a consequence of a single founder effect. A Dutch couple who started their family and had a big family back in 1688. And now they have 30,000 people who have variegate porphyria in South Africa. Remarkable. It's quite a story, but I haven't got time to go into that. But they look the same. I saw these patients with variegate porphyria. They look exactly the same as PCT, and this is how they look. They have, and this is why it's easy to diagnose for us as dermatologists, because the clinical signs are very obvious. There's lots to see. There are blisters, sometimes big intact blisters. There's scarring. There's splits in the skin, so skin fragility. And you can see this patient, lots of blisters, and even, I'm probably going to turn off the whole show here, but oh, there we go, it worked. Yeah, so you can see the unnecessary biopsy. I just wanted to highlight that. I got this off Google Images, and this is photoonycholysis. But you can see really quite florid disease, and this poor patient, all of these cracks and splits, this will be agony, incredibly uncomfortable. This patient is really suffering and will pitch up in your clinic and will be so relieved when you look at them and tell them you know exactly what's going on and you're going to sort them out. Not shown here is milia, but you can get milia. Of course, milia is not specific to cutaneous porphyrias. We see it in various other blistering disorders, but it can be really quite prominent as here. And then the other thing is hirsutis, and this is pretty common, particularly on the face. You can see a woman on the left and a man on the right, and it can be florid, the hirsutis associated with, or hypertrichosis associated with PCT. So we do a fluorescence scan, and we find that the scan is less than 623 nanometers, which immediately excludes 3 porphyrias, as listed there, and then we do the porphyrin testing. So to do a full porphyrin screen, you need blood, feces, and urine, and isocoproporphyrin is specific to PCT and is found in the feces. So, the thing about PCT, part of what makes it a really interesting disorder, other than all the clinical features, is that it's actually a cutaneous disease, but it's the underlying disease process is liver disease. So, which is interesting in itself, immediately means that we have to interact with our colleagues who are hepatologists, and these are the main conditions that trigger PCT. So in the UK, about 80 or 90% of patients with PCT that we see have alcoholic liver disease, but elsewhere in the world where hepatitis C rates are very high, hepatitis C can be the commonest trigger, HIV can also be a trigger, and hereditary hemochromatosis. So any of those. So you've got to immediately, you see PCT, you've got to start thinking and do tests directed at trying to find out what the underlying liver disease is. And the treatment, so again, this makes PCT a highly satisfactory disorder because we can treat it and the treatment's simple and they're cheap. We can do this all ourselves. You don't need to refer. You can sort these patients out yourself. So there are two things we do, and you can do either or. I mean, obviously, iron depletion is more appropriate if they've got hemochromatosis, but iron depletion works really well for any cause of PCT because the PCT is caused by an inhibitor of uroporphyrinogen decarboxylase, which is the enzyme that is deficient in PCT, but it's deficient because it's being inhibited, and it's being inhibited by uroporphyrin oxidase, and the formation of uroporphyrin oxidase is an iron-dependent process. So if you deplete the patient with iron, they won't form the inhibitor, and as a result, the UroD that's there anyway can start doing what it's meant to be doing. So, so the treatment, either iron depletion or low-dose chloroquine or hydroxychloroquine. I think most people use hydroxychloroquine. It's a safer drug, and by low dose, it's just 100 milligrams, so half a tablet twice a week. It's a tiny dose. And what this does is it binds to the porphyrin, mobilizes the porphyrin from the liver, and leads to it being excreted in the urine. So it allows the body to expel the porphyrins from the body. And with either of these two treatments, you can predict biochemical remission within 3 to 6 months. And then, of course, particularly in the UK, where so many of these patients have alcohol-induced PCT, you have to monitor for relapse. The test is very simple. It's just a morning urine, so concentrated urine sample. I forgot to mention, whenever you send any samples to the lab in porphyrias, you've got to wrap them up. In kitchen foil is the best, so that they're completely protected from light. Because if they just arrive unprotected, the lab will reject them, and it'll be very frustrating for you and for the patient. So you have to remember to protect the samples from light. And then you keep an eye on the liver function, and also monitor in case there's a slightly increased rate of hepatocellular carcinoma. So again, if you've got, you should have good overlap with your local gastroenterologist, and they can do that monitoring for you. So variegate porphyria, very similar clinically, but in some respects, the cutaneous features are pretty much exactly the same as PCT. So it's an autosomal dominant condition, but with variable penetrance. And what makes this condition interesting is the different ways it can manifest. So patients can have latent variegate porphyria. In other words, they never actually express the disease. And you might say, well, that's great. They don't express the disease. Game, set, and match, nothing to worry about. But the problem is, if they're latent and they have a drug that they're sensitive to that can provoke an acute neurovisceral attack, it could be that they present with variegate porphyria with shutdown of their autonomic nervous system. In other words, as an acute admission in hospital. And that makes things really tricky because it's actually, that could be life-threatening. So it could be latent, it could be with a recurrent acute neurovisceral attacks. Fortunately, that's pretty rare. The acute attack's much more common in women than in men. So there's a 3-to-1 female to male ratio because of estrogen being a cofactor in increasing the chances of an acute attack. Cutaneous features, some of the patients have cutaneous features just like PCT, and then some of the patients, this is why it's called variegate, it's varied because they can have PCT-like photosensitivity as well as acute neurovisceral attacks. So, diagnosis of variegate porphyria. So, in South Africa, because it's so common, there's a simple genetic test. So it's, but elsewhere in the world, because the thing is, in South Africa, they've all got the same point mutation. So it's a very simple and cheap test. Whereas elsewhere in the world, we have to do we have to have a different approach, and that involves doing a plasma scan, as I've explained, so a fluorescent scan, and if you remember, these ones are these patients are fluorescing above 623 nanometers, and then the absence of clinical features of EPP, and when you actually measure them biochemically, the absence of red cell protoporphyrin confirms the diagnosis of variegate porphyria. So in terms of the skin disease of variegate porphyria, there's not much we can do. So it's, this makes it very unsatisfactory. These poor patients I saw in South Africa with variegate porphyria, they had a sort of chronic grumbling photosensitivity of their hands, and they just had to live with it. We just don't see that in PCT, because in PCT you diagnose it, it can be really severe, but within a few months they're in remission, and hopefully they stay in remission, and that's it, so you don't have to worry about it anymore. But for the poor patients with variegate porphyria, that's not the case. They have lifelong photosensitivity. And then the other issue with this is pedigree testing, doing genetic testing. You might think it's unnecessary, and this feels a bit over the top. But when you think about the possibility of a patient first being diagnosed with an acute neurovisceral attack, just because you haven't gone through the process of trying to identify family members who might be vulnerable to such an attack, then it makes you realize that it is really important. The best example that I know of a family study is Archie Cochrane. So you all know about Cochrane and the Cochrane Library, and this amazing Scottish guy who was the sort of father of evidence-based dermatology. He lived and worked in Cardiff, actually, so we're proud to have an association with Archie Cochrane, but he had variegate porphyria, and it was diagnosed in middle age, and he ended up doing a family study on his own family. And if you read his biography, there's a whole chapter dedicated to it, which I found really interesting. So management, so that patients need to understand about the condition, and importantly, they need to understand about the safe drug list. So this is the drugs that they can take safely and that won't be associated with a risk of provoking a neurovisceral attack. And patients should wear a band, an alert band, and they should be informed that they need to tell their doctors if they've got a new doctor or a doctor they haven't seen before, they need to explain to them that they've got variegate porphyria and there are only some drugs they can take. And if they're being prescribed any drug, they should check before taking that drug. And there's a Cardiff, because we're the sort of, Cardiff was the national porphyria laboratory for the UK. We had a Cardiff, we still do have a Cardiff safe drugs list, but there are others on the internet. So patients need to look them up and be familiar with them. So 2 down, 1 to go, and then we got coffee. So EPP. So this is a very interesting disorder, lifelong painful photosensitivity. So it starts in infancy, and I feel a particular fondness for this condition because we did a huge cross-sectional study of EPP in the UK more than 20 years ago. And so much flowed from that study, not least the recognition that this was an underdiagnosed disorder and often an unrecognized disorder that went sometimes years without being diagnosed, years in which patients were suffering as young children, suffering with painful photosensitivity, which was really ruining their childhood and causing significant disruption to family harmony, and going undiagnosed. They go to the GP, there was nothing to see, because it's all symptoms. So you've got to listen to the story and recognize what's going on. And of course the poor GPs, how would the GP know what they were listening for? So, but when you hear the story, it's always the same. And the story is that basically the patient goes in the sun and within minutes they start suffering with really severe, painful photosensitivity. You only need to watch someone being treated with PDT in the hospital and ask the patient what it feels like, and then think about, because usually when we do PDT it's to a small area, perhaps on the scalp, and patients say it's exquisitely painful, but these children have it all over their body, not just the scalp. So, yeah, pretty serious stuff. So of course it's really upsetting. And the clue that this is not anything to do with ultraviolet is the fact that these patients get really severe symptoms as well on bright sunny days in the winter. So, and what happens is they get conditioned, of course. They get better because the child gets conditioned. They know they have to be in the shade. They know they have to walk down the shady side of the street, never on the sunny side of the street. So they develop a whole load of workarounds, ways of living with the condition. They know that they keep their skin covered up and it won't be painful. So they don't have to be told. They just learn how to cope with it. It's an unusual pattern of inheritance. So it's not most of these porphyrias, well, each of them has distinct genetic features, but this one I think is particularly interesting. So it's autosomal recessive, but rather differently to most autosomal recessive disorders, where you see patients with disease when there are two null mutations on corresponding alleles. But that makes it an exquisitely rare condition because each event is extremely rare. But in this condition, you only need one of the null mutations on one allele, and you join that up with the low expression allele on the other allele. The thing about the low expression allele is it's a common genetic polymorphism that in northern European populations is carried by about 10 to 15% of the population. So when you think that through, all of a sudden you've got something that's way more common than a standard autosomal recessive disorder. And that explains why when we did our UK-wide study, we found hundreds of cases across the UK, whereas most autosomal recessive disease, you just see tiny numbers of patients. So, again, this is not one of my patients, this is just off the internet, but I thought it illustrated it. I hate the way textbooks in dermatology, when they talk about EPP, they show really severe skin disease, because in fact what we see in EPP is nothing. We see normal skin. It's all in the story. So if there is scarring, it's usually very subtle, sometimes tiny depressed scars on the tip of the nose and sometimes on the knuckles as well. So back to how we diagnose these disorders. So again, the first test we do is the really cheap plasma scan. And if you remember, so this is protoporphyrin 9, and I showed you that graph, the dotted line, and the peak of that dotted line was above 623 nanometers. So that excludes porphyria cutanea tarda, congenital porphyria, and hepatic coproporphyria. And then, so it narrows it down to just 3 forms of porphyria, EPP, X-linked EPP, and variegate porphyria. This is nothing like variegate porphyria, so you can dismiss that, and you're into these two. And 95% of these cases will be, in fact, probably more than that. Nearly all of them will be EPP. X-linked EPP is really very rare. Treatment's really difficult. I've left something out on this slide as well. So as I mentioned, the children with this condition and their parents quickly work out that they cover the skin with clothing, which is effective at blocking out visible light. Then their child can play outside in the summer months. So of course that's what happens. They wear a hat, they go in the shade, they wear long sleeve shirts and long trousers, and happy days. Antihistamines, because again, if you remember at the beginning, I talked about one of the secondary effects of release of free oxygen radicals is mast cell degranulation. So antihistamines are logical. UVB phototherapy is an interesting one. So alpha melanocytes, alpha MSH analogues have been used to treat this disorder and have been demonstrated to be effective. So what they're doing is producing a tan. So it's interesting that a tan just tan skin allows absorption of visible light sufficient to make a difference to the symptoms in these patients. Alpha melanotide is a slightly difficult product, though, because it has to be given as a subcutaneous implant every 6 weeks, which is not really very patient-friendly. As you can imagine, it ties them to the hospital. But in fact, there are new synthetic analogues of alpha MSH, which are being developed and are going through clinical trials, which can be given orally. But of course, the other thing we have at our disposal is just giving narrowband UVB. If you give narrowband UVB, patients will tan. And that tanning is often sufficient to make a significant difference to their symptoms. And of course, again, you might think it's counterintuitive giving ultraviolet light therapy to someone who's photosensitive, but don't forget they're sensitive to visible light. And narrowband UVB is way, way down the UV, down the spectrum, is within the ultraviolet B spectrum. It's quite a distance from the visible part of the spectrum, and it doesn't trigger their symptoms. We wouldn't expect it to, and it doesn't. You have to give vitamin D supplements because these patients are very adept at dodging the sun. And when we did our big study, we discovered many of the patients were vitamin D deficient. And that actually led to a whole load of studies on vitamin D in other photosensitivity disorders. It was EPP in particular that alerted us to the very obvious fact that patients with severe photosensitivity often end up deficient in vitamin D. And then following them up, annual ALFTs, some of the patients, a sad sting in the tail for this condition is that some of the patients develop liver trouble with the high protoporphyrin levels precipitating out in the liver and leading to liver damage. Most of these patients have mild anemia, which you don't need to treat, and patients with EPP, they lead long and normal lives, and they learn to live within the constraints of the condition. And of course, many of them get married and want to have children. And then they say, well, is my child going to get it? And the very simple tests that can be done if parents are thinking of having a child and want to understand the chances of their child getting it is just to measure the spouse. So the person who hasn't got EPP, measure the spouse and see if they're carrying the low expression allele. And of course, about 1 in 10 will be. but 9 out of 10 won't. So it's a simple test, and if they're not carrying it, then you can say it's extremely unlikely. You can be pretty confident that your child won't get EPP. That concludes this presentation. Thank you for your attention.
Thank you. Thank you for this very good talk. Is there any question or remark?